Hello, I'm hematologist-oncologist Dr. Tony Talebi, and today I have the pleasure of speaking with Dr. Jorge Gomez, who is a good friend of mine. Dr. Gomez comes from Memorial Sloan Kettering, and he currently is the co-thoracic oncology leader at University of Miami. Dr. Gomez, what is non-small cell lung cancer, and how does it arise in the body?
Non-small cell lung cancer is a difficult disease. It's a tumor of the lung, in general, as the name implies. And it's caused by several different factors that we can identify and some that we have not been able to identify. There are different types of lung cancers. If you look at the non-small cell lung cancers, there are two basic types. There are two basic types now. In the past, we had classifications of lung cancer that divided it into many different types. But currently, when we look at the non-small cell lung cancers, we try to divide them into squamous and non-squamous. The non-squamous varieties are very different. You can have large cell carcinomas, you can have adenocarcinomas. There are some neuroendocrine type carcinomas or non-small cell lung cancers with neuroendocrine features that also fit into these non-squamous tumors. But in general, we have the squamous and the non-squamous because we have different treatments for each one of those two diseases. So we've finally been able to divide lung cancer or non-small cell lung cancer into tumors that we actually treat differently.
Very good. What are some risk factors that predispose one to develop lung cancer?
We know the most important risk factor for developing non-small cell lung cancer is consumption of tobacco. That is the #1 cause of lung cancer. Lung cancer in general is said to be a preventable disease because it's caused by tobacco smoking, and many patients, the majority of patients who have lung cancer and have smoked, may never have had lung cancer if they had never smoked. So that's the #1 cause. There are some other causes that are not as common, but that are fairly common. Exposure to radon gas, for example, can cause cancer. There are certain areas in this country where the exposure to radon gas is fairly heavy. Fortunately, here in South Florida, we have very little radon gas just because of the geographic location and the type of soils and land that's underneath. But that's another one. Asbestos exposure is also one of the causes of lung cancer. It can cause not only non-small cell lung cancer, but mesothelioma, which is a cancer of the lining of the lung, what we call the pleura.
Mm-hmm.
There are other causes of lung cancer. There are other environmental exposures that aren't as clear, and there are some genetic factors, which again are not as clear and certainly not as common. There are certain families that have a tendency to develop lung cancer, but these are fairly rare. As time goes on, though, I think we've identified more and more of the inherited types of lung cancers, although again, these are extremely rare.
Mm-hmm. So you alluded to that, but lung cancer in non-smokers, is that a different disease than lung cancer in smokers?
Well, in terms of behavior, lung cancer in non-smokers seems to be a very different disease. It tends to be somewhat more slow growing, although not always necessarily so. There are some never smokers who have a very rapidly growing type of lung cancer. But it does seem to be a very different disease. There are many patients in the never smoking group which have certain mutations in their cancer cells that we believe actually lead to the production of the cancer and that are actually used as targets for treatment. The vast majority of patients who have that mutation are never smokers. So yes, it is definitely a different disease, but we don't yet know exactly how different it is.
I see. You mentioned the different subtypes of non-small cell lung cancer. Do they have their own history and different biology of disease?
So all of the different types of lung cancers are slightly different in terms of biology. Until very recently, they were all looked at as being exactly the same. Squamous cell carcinoma, adenocarcinoma, and large cell carcinoma were all treated the same because we didn't know how to separate them. We didn't know how different they were. More recently, we've been able to find some biologic factors that make them slightly different and respond differently to certain drugs. They have some different tendencies also. For example, they have tendencies to metastasize to different areas. Adenocarcinoma, for example, is very commonly metastasizes to the brain. They also, in terms of their biologic behavior are slightly different. Squamous cell carcinoma, for example, tends more to produce factors that go into the blood and create issues. For example, it creates one hormone that can increase calcium level and produces that a syndrome called hypercalcemia, which in general adenocarcinoma doesn't. So they are somewhat different in terms of their behavior, but in general, the prognosis is pretty much the same.
I see. When is it appropriate for a patient to seek genetic counseling if they develop lung cancer?
Well, that's a complex question. For a patient who has no significant family history of lung cancer, genetic testing is probably not useful because it may actually produce a lot of anxiety. We don't really know exactly what to do with genetic testing. If we find that you are in one of the families that may be predisposed to developing lung cancer, we're not really sure exactly what to do other than screening to catch cancers earlier. But having one of these predispositions doesn't mean you're going to have lung cancer. And it will kind of put you, give you a sentence of having to be vigilant for the rest of your life and having to be focused on lung cancer for the rest of your life, even though you may never have it. So I think that genetic testing may be important for people who have a very significant family history of lung cancer. So 2 or more other immediate family members with non-small cell lung cancer.
I see. What are your thoughts on screening chest CTs yearly for either smokers or non-smokers?
Well, for many years we tried to create a screening test for non-small cell lung cancer. There are screening tests for breast cancer that are very effective. There are screening tests for prostate cancer that are very effective. But until very recently, we had not been able to prove that either chest x-rays or CAT scans of the chest were able to make people live longer by finding earlier lung cancers. We had been able to prove that we were able to find more early lung cancers, but we had not been able to prove that people lived longer. Now that has finally been shown, that there are ways to organize screening so that you can actually make people live longer. One of the big issues in the screening for lung cancer had been that you also found many benign abnormalities that required biopsies and that required treatment that probably wouldn't have needed to be done if you hadn't done the cancer screening. So you had a lot of exposure of patients to unnecessary procedures and risk. So now we believe that the patients who should be screened are patients who have a fairly heavy history of smoking, whether they've quit or not, and patients who are after a certain age, probably above the age of 55 would be the most appropriate. There are now fairly accepted screening guidelines for patients. But again, it should be for patients who have a heavy smoking history, not for patients who have never smoked.
I see, okay. What is Pancoast syndrome? Would you please explain that to our patients?
Pancoast syndrome is a very interesting type of lung cancer. It behaves a little bit differently from the regular type of lung cancer. It tends to grow in the upper part of the lung against the shoulder and against the spine, and very often invades the spine, invades the nerves that go to the upper extremity, and so it can cause very difficult symptoms such as severe pain, inability to use the arm. It grows a little bit differently from a regular type of lung cancer. It tends not to metastasize to the rest of the body as quickly. And it's treated a little bit differently from other lung cancers. It's treated more aggressively, and it's usually treated with chemotherapy, radiation, and surgery in an attempt to eradicate the whole tumor and take it out so that it doesn't grow and continue to produce more and more symptoms, because it can cause incapacitating pain and loss of function.
I see. You alluded to this earlier as well with the hypercalcemia, but would you please explain to our patients what is paraneoplastic syndrome?
Paraneoplastic syndromes are very interesting, I guess we could call them diseases or illnesses that are related to tumors. Non-small cell lung cancer does not cause a lot of paraneoplastic syndromes, but it can. Small cell lung cancer, another type of lung cancer, much more commonly produces paraneoplastic syndromes. These syndromes are caused by several different things. There are some syndromes that are caused by hormones that are produced by the tumor. For example, the hypocalcemia. There are other paraneoplastic syndromes that are caused by the body's own reaction to the tumor. So the body will create antibodies against that tumor that may actually attack other areas of the body that are not related to the tumor, but that are very similar to the tumor. And so it may cause things like loss of strength because it attacks the nerves and the muscle.
I see. I know we will discuss the specific treatments in the coming videos, but just assume that a patient has had a lung mass and has had a biopsy, which has come back positive for cancer. Just generally speaking, what happens next for that patient?
The most important first step in the treatment of lung cancer is what we call staging. Staging is really trying to find out how far the cancer has gone from the original site. And the way we do the staging includes a lot of different things. The first is biopsies. The second is imaging studies, so we do CAT scans of the chest and sometimes the abdomen. We do many times an MRI of the brain to see if the tumor has gone to the brain, and we use PET scans for staging. PET scans are actually very helpful scans. They look at the body basically from head to legs, and they can identify areas of tumor that aren't visible on other tests. When we do that staging, or the reason to do that staging is, one, to try to plan the treatment, because the treatment is very different depending on how far the tumor has gone from the original site. And the second objective of doing the staging is to try to figure out the prognosis. So the farther the tumor has gone from the original site, the worse the prognosis is. So we can do those two things, decide treatment and try to gauge the prognosis.
I see. Should one stop smoking after they've been diagnosed with lung cancer? Does that make a difference?
Everyone should stop smoking before or after they've been diagnosed with lung cancer. Nobody should smoke. Smoking is a terrible disease. It causes lung cancer. Now, the issue with smoking is that smoking increases the risk of lung cancer, and it continues to do that even after you've been cured of one cancer. And so if you're diagnosed with lung cancer and you stop smoking, your risk of another lung cancer never goes back down to normal. You still have a slightly higher risk of having lung cancer, another lung cancer, than anyone else. If you continue to smoke, that risk continues to increase.
I see. What about secondhand smoking? Is there association with lung cancer as well?
There's a definite association between secondhand smoking and lung cancer. It isn't as clear as the first-hand smoking because secondhand smoking is very difficult to quantify. It's very difficult to figure out how much exposure somebody has had to secondhand smoke. But it is clear that secondhand smoke does cause a fairly similar amount of damage as first-hand smoking.
I see. And you alluded to this earlier as well, but would you please explain to our patients the genetic mutations that have been discovered? For instance, what is EGFR? What is ALK?
There are two abnormalities on lung cancer cells that have been identified that have been used as targets for treatment. The first is what we call the EGFR mutation. EGFR is a receptor on the surface of lung cancer cells. And when it's mutated, it seems to be, to put it in an easy way, turned on and to drive signals that go into the cell and make the cell reproduce, make it grow, and stop it from dying. And so there has been a drug that's been developed that can turn off that signal, and that allows the cell to die, that stops the cell from reproducing and continuing to live. That really has been the first targeted therapy that was found in lung cancer, and it has been a tremendous success in patients who have that EGFR mutation. In some populations, that's about 10% of the lung cancer population. In others, it's 15 or 20% of the lung cancer population. So it doesn't happen in most patients with lung cancer, but 10 to 20% is still a fairly large number. The second, what we call mutation, is called the EML4 ALK translocation. This is another, what we believe, driver of lung cancer that has also now been used as a target for treatment. And there is a drug called crizotinib that can be used to turn off that signal again and to make tumors shrink. Unfortunately, this translocation is really present only in about 4% of the American population, and so it's much less common, but for patients who have the translocation, there is a treatment that may be better than chemotherapy.
I see. When there's a trend towards personalization of cancer treatment, is that happening in lung cancer as well? Where are you guys with that?
Well, I think personalization of treatment of lung cancer is very important. The problem is that we don't have drugs for every type of lung cancer or cancer in general. One of the problems we have in lung cancer is that lung cancer is very heterogeneous. It's not just one cancer. Breast cancer is a couple of different types of breast cancer, but lung has innumerable types of lung cancer. Almost every patient is completely different from every other patient. And so to personalize it, we'd have to treat every patient differently. The steps that we've really been able to take in terms of personalization are, first, the identification of the EGFR mutations and the EML4 ALK translocations. That really is a very directed treatment towards that patient. And the other big step is really the identification of drugs that work better in certain types of tumors. For example, a drug called Alimta works better in patients with adenocarcinoma than with other types, than with squamous cell carcinoma. And so while that's a nice step in terms of personalization, we're still not able to really treat one patient. We treat the segment of adenocarcinomas, we treat the segment of EGFR mutated or patients with EML4 ALK translocation. And those are really big steps in lung cancer, but overall they're still pretty small.
I see. Are there any support groups that exist that you recommend to your patients?
There are many support groups for lung cancer. Probably the most important source of support groups is the American Cancer Society. The American Cancer Society has a very good website. They have, in general, offices in most of the states and have offices in all of the different areas of the state. So if you go on their website, you'll be able to find support groups for every type of cancer, including lung cancer.
Okay. Thank you so much, Dr. Gomez. We hope this has been educational for you. In the coming videos, we'll discuss specific treatments of non-small cell lung cancer. Thank you.